Hello and welcome to
Hi.
Dr Malini. I can't thank you enough for taking the time to come to speak to us. We're
this is
so
great.
so grateful. So Dr Malini is a consultant gynaecologist. And I checked the information on the Cosmedicare website because Dr Malini, as well as doing other things, which I'm hoping you'll explain anyway, she also will be working with Jill Baird at Cosmedicare. And thank you so much, Jill, for arranging this. We're so grateful. So I took this information right from the website for Cosmedicare, just to give people a wee bit of a background of what your expertise is, and then we'll just go straight into the questions, because I'd said to you I'd ask my followers for some questions. So you carry out consultations for menopause issues, HRT, contraception, problematic periods, painful sex, bladder issues, early pregnancy scans, pelvic scans, cervical smears, endometrial biopsy and vulval biopsy. However, you have a standout expertise, it said, quote unquote, in menopause care. Did you know?
No, I didn't know. So I have a special interest in menopause care.
Yes.
I also do contraceptive coils and the hormonal coils and implants as well. So
excellent, because I've got a few questions on that too.
Sure.
So I just want to get right into it, because as I've said, I want to be able to ask as many questions as my followers.
Oh my gosh,
there's
okay,
loads,
that's a big
honestly.
list.
But what I've done is highlighted the ones that have probably been asked the most, so that we can try and answer as many people in one time. So we're just going to start straight away by asking what you would say to someone that came in and said to you, please explain to me the advantages and disadvantages of HRT and whether body identical versus artificial is the way to go. So what would you say?
So lots of advantages and disadvantages to think about. I mean, I think the main thing to remember is it's not a one size fits all.
Yes.
So, you know, when I'm seeing somebody for a sort of menopause consultation, it's about looking at all the different factors in that woman's life. So you look at the previous medical history, you look at the symptoms that she's going through, you look at her contraceptive needs, you look at her periods, so you're trying to look at the whole package, just to see what is actually the most important thing that this woman wants to get out of it. And with HRT, as I said, it's not a one size fits all, and it's not something that every woman must have or can have. There's obviously women who have certain medical conditions that mean that they can't have HRT.
Yes, and those ladies contacted me as well, so I will ask you to talk more about that.
The alternatives as well. So, so then it's thinking about the alternatives or things that you can do to address individual symptoms, just to try and make life a bit easier. And for some women, they may not be going through much in the way of troubling symptoms, and maybe they don't want to use HRT. So it's also addressing all the other things around, that change as you go through the menopause, and the health changes that you will experience. So, how do you address issues like, your risk of osteoporosis, your risk of heart disease. A lot of women talk about weight gain around the time of menopause. So, there's all these little things that you can also think about, like the lifestyle factors, diet, exercise, smoking, all of that kind of stuff as well.
And from what I have seen in the questions that I received, I think many women are looking for someone just to say to them, that's what you need to do. There's the answer, that's what you need to do. And is it fair to say that's not the answer?
You can to a certain extent say that's what you need to do, but it's not as simple as just have this HRT and that's going to solve all your problems. It is looking at all the other factors, as I said, like the lifestyle things as well, because again, when you talk about the risks and benefits of HRT, one of the risks when you're using combined HRT is a small increased risk of breast cancer. Now, it is a very small increased risk, and it is it does go up when you've been on it for a long time, not sort of when you in the early stages, in the first few years of using HRT. And that is something that does scare a lot of women. Breast cancer, it's an awful thing to think about. If I take this, am I going to end up with breast cancer? But what a lot of women don't realize is that small increased risk of breast cancer with HRT is just a small increased risk. If you look at the increased risk with smoking, with being overweight or obese, of drinking too much, those risks far outweigh the risk of the HRT. So you do have to also think about all of these other factors. It's not just the HRT.
Yeah, and that is definitely still a big fear among women, because the questions that I received were, this frightens me, HRT frightens me, because that's been the narrative for so long.
And it's just looking at it in context and looking at, the relative risks of all of these things. And, when you weigh that up against the benefits of, decreased risk of osteoporosis, a decreased risk of heart disease, symptom control, because for some women the symptoms can be so severe. Not for every woman. Some women sail through menopause, minor symptoms, and then they're through it and they're done. Some women do have some troubling symptoms, but I do see women who have such severe symptoms that their whole lives are turned upside down.
Yeah, I've had many of them in my inbox.
And there's a significant number of women who actually give up work around this time because symptoms are so severe. And that's awful. I mean, these poor women are going through a terrible time with relationships, with work. They're having to give up work, and this puts them at an economic disadvantage, and this should not happen. It's the benefits of symptom control can be huge for some women.
And I have had a lady contact me that said she had to resign from her job. I had another lady say, please help me, I feel like my life is over. I mean, that absolutely breaks my heart. I'm not having a consultation with that person, so I don't know the full extent of
what's
it
going on,
or what solutions that she's tried. But another thing that seems to be a massive problem is getting a GP to refer or even prescribe HRT.
Yeah, so it is difficult accessing appointments, and the problem is GPs are overrun. They're working really hard, and there's just not enough GPs for the number of patients that need to be seen. So I can understand that there are difficulties, and there are GPs who do prescribe HRT and do it very well, and it's not something that every GP has an interest in. So I suppose you can't really expect every GP to be 100% up to date with everything to do with menopause and HRT. They've got so much that they have to deal with. There are some really good resources out there that I think it's useful if you're thinking about seeing your GP, maybe access the resources first. Have a look at all the information. So if you go to your GP and you're better informed about your choices and what you like, it makes it easy if you say, okay, I've read up on it, I understand the risks and benefits, I would like to try this. That does make it easier for the GP.
Yeah, and I would echo that from my personal point of view. And I say that about everything. You need to self-advocate. It's just not going to happen if you walk into that GP's office and say, this is what's wrong with me, please help. It's just, it's not, you need to go equipped with information.
And you do need time to get through all the, there's huge numbers of symptoms that somebody can present with. And, it's trying to tease out, okay, what can we do? So a really good website is the Menopause Matters website, run by Dr. Heather Curry. There's also plenty of information leaflets from the Women's Health Concern, so that's part of the British Menopause Society. So I would say go to the reliable websites, because there's a lot of people posting stuff that's not always entirely accurate.
I heard someone make a comment about Davina McCall, and I love Davina McCall, right? So I'll say this, that it was another doctor had said, it was a lady that messaged me, she'd gone to her doctor, and she said, this doctor had said to her, you know, if it was up to Davina McCall, you'd be bathing in it. And I thought, right,
I mean, what Davina's done is bring it forward and bring it out into the open. So that's not a bad thing.
No, it creates that awareness, I know, but it just, for me, it threw in that you do need to do your own homework. You know, it's just not one of those things where somebody's going to tell you the answer to your issue, whatever that is. You have to do the research yourself. So just going back to that question then, body identical versus artificial. Now, I'm not even sure which one's which here, because I'm on the Everall patch, you know, and it's been amazing for me. But what is that? Is that artificial?
So you've got the synthetic hormones, which are in a lot of different types of HRT in the contraceptive pill. And then you've got the hormones that are as close to the body's natural hormones as they possibly can be. So that's estradiol and the micronized progesterone. So that's the utrogestan, basically. So there's been this big thing about, we will provide you with the exact same type of hormones tailored to you. And, there has been, I think, people taking advantage of women by saying, we'll do various blood tests and then we'll tailor it to you. And, I think it's a bit of a scam, to be honest.
Oh, okay.
You can't take somebody's, I'm menopausal. You can't take my blood sample and say, I'll give you something that will make you feel like you're 30 years old again, because
it's not happening. It's just not happening, right?
You can't tell what my hormone levels were when I was 30 years old.
Right.
Right. So they're trying to say, we'll tailor it. It's like, no, I mean, HRT comes in standard doses.
Right. Okay.
And you tailor the dose depending on symptom control. And again, it's not a one size fits all. For some women, they prefer a tablet. There's the option of patches, there's the gel, there's the spray. There's different ways of taking the HRT, and one method is not going to suit everyone. And again, it's tailoring the dose of the HRT to that woman's symptom control and her needs.
Right.
So this is all available in standard HRT. You don't need to go and get specialized blood tests.
So you wouldn't do that?
I very, very rarely do blood tests.
So you do exactly what your job says. You're a consultant.
Yeah, so I mean, there are women who do need blood tests, don't get me wrong. Okay. So it's not that nobody ever needs blood tests, but you have to think about the reason you're doing the blood test. So, obviously if somebody's going through an early menopause, you would want to confirm that with a blood test. So there's a specific reason for checking the hormone levels. If, say, somebody is not getting good symptom control despite being on a really good dose of HRT, then, you might be questioning, are they actually absorbing? So maybe then, yes, you do want to check their estrogen level to see, is it within a normal range, or is it very, very low despite the decent dose of HRT they're on? Because some women don't absorb very well. So again, yes, then there's a reason for doing the blood test. But generally, you don't need to. If you're at the age where you are likely to be perimenopausal or menopausal, if you're experiencing those symptoms, if your bleeding pattern's fitting in with that, then why do we need a blood test? We don't.
Yeah.
Just get on and deal with whatever it is you need to deal with, or whether it's HRT or alternatives.
And that was another thing people were asking me about, how do I know if I'm perimenopausal or menopausal? And I know that in the UK the NICE guidelines are used, which is simply, it's really just an age thing, to be honest, because having read it, if you're 45 or over, I mean, that's the thing. The fact of life is we're all going to go through, all us women are going to go through perimenopause and menopause. So I can see why they don't test everybody. It's like you'd be testing every woman in the whole of the UK, and that's just... I understand it's a bit daft when we're all going to go through it anyway.
So the average age in this country is about 51.
Yeah.
So some women do go through it a little bit later, some women do go through it a little bit earlier. And if you're 45 and over, you can expect that this is going to happen at some point.
Yeah. So then you would just, as a consultant, treat on the basis of assumption that this is what we're dealing with,
so you're
because
looking
that's
at,
the symptoms.
so you're looking at the pattern of the periods, the symptoms, the age, and going, this is likely, this is what it is. So we don't need to be doing blood tests.
And I think, being totally honest, Doctor, there is a massive misconception with that, and I think it's just purely because the information's not easily out there. And I know myself, when I was approaching perimenopause, I thought, I'll need to phone the doctor and get this confirmed. It's just, you don't know what you don't know. And it's not until you delve into it that you go,
no, I don't need.
So then, you're doing your own research. So that answers that question.
With oral estrogens, there is an increased risk of blood clots in the legs and the lungs. If you're taking your estrogen transdermally, so through the skin, there isn't that increased risk.
Yeah, right. So the patch would lessen.
The patch, the gel, the spray would decrease that risk, or take it away, essentially.
Okay, right. Testosterone. Hundreds of people asked about this, and I've never actually even thought about it until now. And I'm thinking, should I be thinking about this? But
not everyone needs it. No.
Yeah. So how do you?
Yeah, it's one of these really difficult areas. So a woman's testosterone levels don't just drop dramatically at menopause. They're actually kind of, it does start to go down slowly when you're in your 30s, 40s, but it's reasonably well maintained, even through menopause. So there's also this huge area of uncertainty about, exactly how useful it is in low sexual desire. So testosterone can be prescribed for women who have low sexual desire. It doesn't work for everyone, and there's lots of other factors to think about as well. So a lot of women who are coming to me and saying, I've got terrible symptoms, the flushes, the sweats, I'm not sleeping, my mood is terrible, all of that, no libido. And then you think, well, if you're feeling so terrible, why do you think you would have a sex drive? You know yourself, if you're in a bad mood, or if you're stressed or upset, your sex drive just goes, doesn't it? So it's not, so it's one of these things, I think, let's try and resolve all of these other issues first. Let's get you feeling better, sleeping better, let's get your mood a bit more stable. And then let's see what happens to your libido at that point. And if it's still not improving, and again, there's other factors to think about as well, like the relationship. No amount of HRT is going to fix a broken relationship. So sometimes the libido issue is not to do with the menopause, it's to do with there's a problem within the relationship, for whatever reason. So, again, it's having to look at all of these different factors. And just see, is there a cause for this? And so for some women, once all the other issues are resolved, like, they're sleeping better, they're feeling better, all of that, they don't need testosterone because, their sex drive is back to normal, or reasonably normal.
Would that be the only reason for taking it? Testosterone?
Yeah,
so it can be dangerous, can't it? If the dose is
only if you're taking too much. So you do a blood test before you start, and then you do a blood test 3 to 4 months after starting, to make sure that it's staying within this sort of safe female range. So it's very rare to get side effects if you're within the female range. It's only if somebody's using far too much, then you might get some side effects. So it is something that can be prescribed by a specialist.
Yeah, because
it's
GP
not,
doesn't. Yeah.
Yeah, because it's not licensed for use in women yet.
Oh, right.
Yet.
Oh, okay.
I'm hoping at some point, yes,
right.
it will be. So it does need to be prescribed by a specialist because you do need to monitor the levels.
Mm-hmm. That alone, though, from what you're saying, is not a single solution for perimenopause or menopause symptoms, though.
So some women do say, it makes them feel like they have more energy, there's mood effects, but there's no evidence to say it does anything other than, use it for treatment for low sex drive.
Right, for libido.
Yeah.
So you would be, if someone came to you with perimenopause symptoms, you'd be looking to try and resolve everything else before you looked at that.
Yeah, so
right,
I tend to not jump straight to testosterone until everything else is a bit more stable and sorted.
Yeah. So if you were, so this just links into this question, do you need to be on HRT to take testosterone? So if somebody was getting prescribed testosterone, would they need to be on the HRT first?
Well, apparently you get more of a benefit from it if you're estrogenized, so you'd probably be better trying the HRT first and then adding the testosterone if you needed it.
Right, okay. So once you start patches then, when do you know when you're over the whole perimenopause and you're in menopause to then stop the patches? And there was a lot of questions about that. When do you stop?
Timing of everything.
Yeah.
So perimenopause is that time where you're leading up to the menopause.
Mm-hmm. Yes.
So you start to get symptoms that can come and go. Your periods can become a bit erratic, and it can sometimes be over quite quickly, but sometimes that time can stretch on for years. Mm-hmm. And then menopause is when you have not had a period for a full year. Mm-hmm. And then you're postmenopausal.
Yeah, but then some women think they're postmenopausal, and out of nowhere a period appears. I've had a few women say that. Yeah,
because it's not always like, you're premenopausal, then you're postmenopausal. It's not always like you're falling off a cliff. It's, you can get little fluctuations and it can stretch out a little bit. So we usually tend to say if you've not had a period for a full year, then, you should be postmenopausal. Yeah. So, if you do get any unusual bleeding after that time, that does need to be investigated as postmenopausal bleeding.
Right, okay.
But if you've not had a period for 3 months and then you get one, then that you're still perimenopausal. Mm-hmm. You might still be kind of at that stage where things are coming and going and maybe not as regular, but you might still have some bleeding.
Right. So in terms of then coming off the HRT,
well, you don't need to.
You don't ever need to. See, my prescriber said that to me as well, but I didn't want to do that.
So there's a caveat with all of this. So there's no time limit. Uh-huh. If you are getting benefit from it and you want to stay on it, then you can stay on it for as long as you want. But you do also have to sort of realize that your medical history can change over the years. So maybe what was fine at this stage, if something develops in your medical history, it might not be fine, later on. Mm-hmm. Like say I'm on HRT now, I'm happy with it, no problems. Say in 10 years' time I get diagnosed with breast cancer, of course I have to stop my HRT.
Mm-hmm. Okay. So see, even on HRT then, and you're so I'm just newly on it and I'm still getting an occasional period, right? And it's probably brought it on more, and she did say that would happen, you might experience.
So it depends on what type of HRT you're on and where you are along that sort of journey of being premenopausal, perimenopausal, postmenopausal. So when you're perimenopausal, you will still be getting some periods. Mm-hmm. So if you're on a HRT, you would be likely on what we call a sequential preparation. Mm-hmm. So that's designed to give you a monthly bleed.
Right.
And it just helps to regulate bleeding, because sometimes when you're perimenopausal, some women do get horribly irregular, frequent bleeding, can be very heavy. So the sequential preparations kind of help to sort of give you a monthly bleed.
Okay.
Once you are postmenopausal, then you go on to what we call a continuous combined HRT.
Right. So
that's designed, that's kind of a no bleed.
Right, okay, so that would
Yeah.
be something you'd be continually speaking to your care.
Yeah, so at some point you
giver.
would switch from the sequential, and generally we say, you shouldn't be on the sequential for more than 5 years.
Right, okay.
And then you switch to the continuous.
So for me, for example, just to use as an example, if the bleeding, has stopped for a full 12 months on the HRT that I'm on, I would then look to go back to get the next form of
maybe,
treatment.
Switch to the continuous.
Depending on how I felt or whatever.
Yeah.
Right, okay, so that brings us on nicely to the ladies with either previous breast cancer diagnosis or also had a lady who has the gene, so had the double mastectomy. So these ladies were all asking basically, when you can't use HRT for medical reasons, what are the
options? Yeah, so there are some alternatives. So there's a new drug that's come out called Veoza.
Yes.
Or the
Somebody
neurokinin
might have mentioned that.
Right, yeah. So it's literally just come out.
So it's not available yet?
I think it's available on private prescription, but I'm not sure. I need to check, because all new drugs have to go through an approval process. In Scotland, it's SMC approval so that, it can be prescribed on the NHS.
Yeah.
So I don't know where along we are in that.
So it's probably worth saying at this point, you work privately as a gynecological consultant, and it's different to what can be offered in the NHS. So sometimes...
I mean, it's fairly similar, because again, I tend to follow guidelines. So if something's approved or safe, I don't go with odd, weird and wonderful, creams and gels and things that are not medically prescribable or approved with no evidence base behind them.
So you're not...
my prescribing practice...
That was really what I was trying to say.
But it's very similar to what I would be prescribing on the NHS.
It's just that in the NHS it's actually quite challenging to get a gynaecologist appointment and be referred. So it is an option to go private. I know it's going to cost more, but it's sometimes, it's like everything. If you feel you need to invest the money in it, then that's what you do. And many women do, because you're a busy woman yourself. The alternative. So there's that drug. So you're not sure if that's available. So
so I do need to check whether it has been SMC approved yet.
Right.
But so there is. So it's great, that there is a new drug. That's for flushes and sweats. And there's other things that you can do to deal with symptoms. So, we do know if you exercise regularly, if you have a healthy diet, if you're not overweight, if you don't smoke, you can take alternatives like venlafaxine or, once this new drug is more readily available. And, for certain symptoms, like things like vaginal dryness, you can use, vaginal moisturizers, lubricants. You can use the very, very low dose estrogen pessaries. So, there's ways around some of the symptoms that don't involve HRT.
Right, so that would be very much symptom specific.
Yeah, so
in those cases.
Yeah, and there's also, just little things like, wear layers, wear breathable clothing. Make sure you have access to cool water, a fan. If you're at work, can you get a table near an open window, to help cool you down if you get flushes and sweats. So sometimes it's just, sort of little physical things that you can do
to try and help
with the symptoms.
What was that drug you did name there? What did you say?
Venlafaxine.
Right, so I take it that is something that is available for ladies in that. Right, okay. Because this particular lady said she was on tamoxifen. I was assuming that was a breast cancer related medication, so that would be hot flushes, she was saying particularly. So that drug that you've stated there, does that help?
It's non-hormonal, so it's not going to increase your risk of a breast cancer recurrence.
Right, okay. And it does help with all the usual symptoms.
Flushes and sweats.
Right.
You know, it's also things like, you know, thinking about your osteoporosis risk, you know, so, you know, make sure that you're getting enough calcium in your diet, vitamin D,
so vitamins is one.
exercise,
Yeah,
you know, low impact exercise. You know, so I tell all my ladies, you do need to think about all the lifestyle things.
Yeah, it's major.
It is very important.
Right,
You know, so making sure that your diet is as varied as it can be, you know, cutting down on ultra processed foods, cutting down on sugar, because we do tend to, you know, quite high sugar diets. I mean, I've got a sweet tooth, it's terrible. Yes, I do. I know I need to cut down.
I did too, but I had to do something about it. Yeah, no, I can totally relate to that.
Yeah.
But so lifestyle is a massive, massive thing.
Massive thing, yes, absolutely.
I don't think people really appreciate that either, because women are so desperate, they're just looking for something to be prescribed to fix it, and just not really realising that lifestyle.
Yeah, because there's a lot of things you can do to help yourself. And it's big changes. And it's not always easy. You know, if you are in the middle of a busy job, you've got kids, and then you're having to deal with all of these symptoms, and then somebody's saying to you, take some time out of your day to get some exercise. You know, for some people it's like, when? Where am I going to do that? You know, in between everything else that I have to do. But it is important to do that.
No, it's definitely something that women need to focus on and prioritise themselves with.
Absolutely.
So that brings us nicely on to the vitamins that you mentioned there. That was specifically asked by one of my ladies. What vitamins do you recommend taking as part of it?
You don't really need to take a huge amount of multivites. Vitamin D is the one thing that, you know, pretty much everyone in Scotland does need to be taking. So the vitamin D, absolutely yes. For some women, they may need iron supplements. You know, in the sort of perimenopausal period, sometimes some women experience like horrendous bleeding issues, you know, to the point that they are getting anemic. So, you know, sometimes you do need to take an additional iron supplement if you are experiencing those types of things. If you don't have a lot of dairy or enough dairy in your diet, you might need to take a calcium supplement as well, for your bone health. You know, but other than that, really, you can get pretty much everything you need if your diet is good. You know, so you need to make sure that you're getting, you know, that wide variety of different colours of the fruits and the vegetables, seeds, grains, nuts, oily fish. So, you know, making sure you've got that wide variety, so all those micronutrients are coming from your diet, not from a tablet.
And I think, so I did know that as well. You're actually better to consume in the form of food everything that you need, rather than take supplements if you can. But like you say, vitamin D is one that we just don't have a choice about in Scotland.
And there's so much information now about the gut microbiome, and you know, having a healthy gut actually has huge health benefits. So, you know, again, it's not just about what micronutrients do I need. It's also like, how do I improve my gut health?
And there's loads of people online that focus on that and do that. And
so
I think
Tim Spector's somebody that I do think we need to listen to. So again, it's really difficult when you're looking online. There's a lot of people trying to push, you know, the latest tonic or the latest, you know, this is great, or, you know, drink this or eat that. And, you know, again, just be sensible. You don't need to spend huge amounts of money on fancy supplements. It's look at the diet, look at what you're eating, what can you cut out, what can you bring in.
This links in nicely to one lady had asked me that she takes menopause as an alternative to HRT, which again, I know nothing about menopause. I know what it is, I've seen it on the shelves.
You know, it's multivites, isn't it?
Yeah, multivitamins. So it just goes back to what you're saying, that your take on it is to try and consume what you need from.
But, you know, obviously not everyone can. You know, if you absolutely can't stand dairy, You know, I'm not going to say, go on, just chug the glass and milk, you know, just say,
Yeah, you're not.
if you're
You're not
lactose
trying to make the
intolerant,
torture worse.
Exactly, if you're lactose intolerant. You know, so for some people, they are restricted a little bit in what they can eat and drink. So, you know, sometimes, yeah, you know, you do need to take a supplement to overcome that.
Yeah, right, that's fine. I think you've answered that perfectly. So I want to move on. Well, actually, just quickly before we do, there was a few ladies that had messaged me as well in their 30s, 30 to 35, concerned that they're experiencing symptoms of premature, would you call it that? Premature menopause?
Yeah, and I think sometimes it isn't premature menopause, it's actually PMS. Because there's a significant overlap in symptoms. So
that's interesting.
So it is worth actually, you know, keeping a symptom diary to see, you know, are these symptoms that I think are perimenopausal symptoms, are they all kind of clustered around a particular time of the month every month? You know, and symptom diary, there's lots of information on PMS. What is it? Is it NAPS, the National Association for something like that? But again, you know, look at the reliable websites, and there is a symptom diary available online. So again, it might be worth, like, you know, keeping a symptom diary to just try and tease out, you know, are my periods regular? Because if you've got regular periods, then it's unlikely that you're menopausal. If you've got symptoms that are, you know, clustered around a particular time of the month every month, then maybe it's more likely to be PMS. But early menopause or premature menopause does occur. So, you know, it is worth getting that checked if you think you are going through a premature menopause. Because again, your risks of things like osteoporosis and heart disease are higher. And we would recommend that if you go through a premature menopause, that you take HRT until at least the natural age of menopause.
Right, okay.
To help it.
That's interesting as well, because another lady said that she is actually in the stage of premature menopause, and the doctor is not keen on prescribing HRT. She said that he said try and push through it. I know, and that just makes me want to cry for women. It's just like, it's so unnecessary, but you know, that's one of the things, and I suppose I'm just highlighting what a lot of women are up against. I know I have been extremely lucky. There's a nurse in my practice who prescribes and specialises and runs a workshop and is also perimenopausal herself. It helps so much when the person that you're seeing knows, because they know.
Yeah, they've experienced all of that. Yeah,
what
they know it's not just a minor inconvenience.
Yeah, they know how challenging it is. So I'm going to ask a couple of questions about contraceptive pill and coil, because I did get quite a few on them. The mini pill, I'm on the estrogen mini pill. Can that hide perimenopause symptoms, and is it possible to diagnose perimenopause on this? That's not something I personally know about.
No, so it will be the progesterone only mini pill.
Right.
Yeah. Okay. So no, so I mean, if you're going to go through menopause, you'll go through menopause whether you're on the pill or not.
So it won't affect.
The combined pill, it can mask the symptoms, because the combined pill is estrogen and progesterone, which is what HRT is as well, but different doses. Right, okay, and that's what...
Sorry.
And the other thing to remember is HRT is not contraceptive.
Well, that's the next question, because my mind was really having to work. Can you still take the contraceptive pill while on HRT? I have endometriosis, this lady said.
Oh, gosh. So, you know, so when you're perimenopausal, you will still be ovulating, maybe not regularly, but there is still a pregnancy risk.
Right, okay.
So, you know, so if you are starting on your HRT when you're perimenopausal, you still need to remember to use some form of contraception if you're not wanting to get pregnant.
Right.
And a lot of women, you know, when they're in their 40s go, the chances of getting pregnant are so low, you know, but it's never
the writing's on the wall,
it's never zero until you're post-menopause.
Right, so you do need to take...
Yeah.
So for me, I have the coil, the Marina coil fitted. I had that anyway. So when I then go to see it, I know loads of women are in this same scenario. When you then go to see about HRT, you only need the estrogen part of it. So that's
so as long as your coil's within date, so it's
yes,
5 years. 5 years for HRT.
It's only 2 years. Yes, it is. I checked that.
So then, and it's a really good option for women who are perimenopausal and having irregular or problematic bleeding. Then that's a really good option to have that. The 52 microgram coil.
Yeah, that was why I got it in the first place. Yeah. So it's good to hear that. Yeah. I'm going to cut this bit and play it in my stories over and over again. It did help me with my periods anyway, but I know, again, that doesn't help everyone, but it's good that, it's there as an option, I suppose. So, moving on, perimenopause, these questions are now, and the things that were coming up was specifics like migraines, anxiety every day, acne, panic attacks. One lady felt like she was having a heart attack on a daily basis.
It can be quite bad.
Insomnia, people really, hair loss was in there as well. But I'm going to say about hair loss separately, not because of me, but because this woman has asked this. But see all those things that we've talked about, all those symptoms, the migraines, the anxiety, acne, insomnia, these are the things that you don't hear as much out in, social media or in the media or whatever. Are these things that you would try and fix other ways, lifestyle changes or whatever, before HRT? Or would you think that there was a direct link?
No, there is a direct link. So there's lots of different symptoms that women can experience when they're going through menopause. So it's not just the traditional flushes and sweats that everyone thinks about. There's things like increased frequency of migraine, the insomnia, hair loss, joint aches, dry skin, dry eyes, vaginal dryness, painful sex, loads of different symptoms. So I don't see the point in sort of saying, we'll just up your migraine meds and, we'll, do this and do that. Sometimes it's just a case of it's all kind of tying in with menopause, and, we know that HRT will help the vast majority of these symptoms. So, sometimes it's just go with the HRT, give it a try. But, obviously with the other lifestyle changes as well, because, there are some people who know what their triggers for migraine are, so work on avoiding those triggers as well. So again, you don't want to be prescribing HRT and saying that's the solution, doesn't matter what else. You do have to work on
but at the same time, if somebody came to you presenting with all those issues, then I would be
let's try HRT. If it was possible, then yes, let's try HRT.
Right. And that brings me on to the next question. A lady, and I had said this in my own podcast when I was talking about HRT, because when I got put on it, I was quite sceptical. I'm not now, I've changed completely. But I was sceptical because I said to her, well, if it doesn't work, if you're giving me this and you think that's going to solve everything, if it doesn't work, I am not continuing to take it. And her words were, it won't do nothing, because she was Irish. And she was right, it didn't do nothing. But is that okay if because there was a lady messaged me saying, I've just started a 12-week, which was exactly the same as me, a 12-week course of HRT. Is that something you would actively say, look, why don't you try this? And if it doesn't work, you can just come off it again. And there's no kind of a health risk attached to that?
Short term, and depending on what type, there are very few health risks.
Right, okay.
The risk of breast cancer, the risk of blood clots in the legs and the lungs, all of that kind of stuff, we're not going to say there's zero risk, but if you're going to try it, you need to give it a reasonable length of time, because it's not going to work instantly. It does take time for it to work properly. And some side effects, again, it can take a little bit of time for you to get used to it and for the side effects to settle down as well. So I hate it when I see people chopping and changing very quickly. You know, I tried this, it didn't work, so a month later I switched to something else, and you know, and that didn't work either, so I switched to this. And it's like, no, just let's start with a standard dose, give it a reasonable length of time, and then sometimes we do need to adjust the dose, or we need to adjust the type of HRT that you're getting, because again, it's not a one size fits all, but it's, you know, having the patience to give something a reasonable length of time to work before saying it's not working, and then maybe it needs a bit of adjustment or a change to something else.
Yeah, so would you say a reasonable time is 3 months?
Yeah, at least 3 months.
3 months.
So I usually say 3 to 4 months. So a good thing to do is you start a symptom diary before you start your HRT, and then you do it again 3 to 4 months later.
Right.
And then you do it again another 3 to 4 months later. So you can actually look back and say, okay, what were my symptoms like? What's improved? What hasn't improved? And you know, and sometimes you don't get perfect symptom control, but you know, it's worth trying to adjust things to try and get it as good as you possibly can. You know, while you're doing things like, you know, working on your diet, your exercise. You know, and there's again some really good information on sleeping. So the Sleep Council, they've got podcasts, or they call them nodcasts, and you know, just handy hints and tips of, you know, how to improve your sleep pattern. Because again, you know, do see a lot of women when they've had quite a long spell of insomnia or sleep disturbance, everything else seems to kind of resolve. You know, they've got really good symptom control, but the sleep pattern's still not great. So again, you do have to work on that. You know, you do have to do a little bit of sleep training to try and get into a good sleep pattern and improve your sleep.
It was sleep for me that finally made me go to the doctor, because I'd done.
So tired,
I do,
you know.
and it's like what you were saying about the libido thing. You know, sleep affects so many other things. So you might be blaming your anxiety, your mood swings and everything on perimenopause, but actually that, although it's a, you know, around the road kind of symptom, once the sleep was fixed for me, and my sleep was sorted within 3 days, going on the 50 50 milligram, is it? Patch 50 anyway. And that just honestly, it made me feel like a massive weight had been lifted. Brilliant. So it is, you know, worth, I don't even know where I'm going with that now. I've totally lost my train of thought.
It's worth working on that separately
as well. But I did know that worked for me, and it linked into another question that a lady had asked that she's really suffering with insomnia. I think she's on the 75 overall, and she was asking if I ask for it to be put up to 100, might that help my sleep? So if you've done everything else, like like lifestyle options and whatever, is that, you know, the next step?
So if you don't have good symptom control, then, you know, you may need to increase the dose. And you know, increase the dose, give it a few months to see if that's settling down, you know, and if it's not, then, you know, do you need to be on the maximum dose? If you're already on the maximum dose, still with poor symptom control, then, you know, maybe it's worth checking the levels to see what are your levels. Are you actually at a reasonable level, you know, to be expecting good symptom control? Or, you know, if you're, say, on a transdermal preparation and you're not absorbing it very well, maybe your levels are just really low and you're just not getting enough. Even with that maximum dose. So, you know, do you need to go above the recommended dose or switch to a different method altogether?
Right, okie doke, smashing. So the hair loss one, this lady said, experiencing lots of hair loss, will it ever come back with the right hormones?
Not always, no, because there's lots of different reasons for why women have hair loss. So again, it's also worth looking at things like, you know, getting your ferritin levels checked, your thyroid function, you know, to see is there anything else going on. You know, and some women do get lots of hair loss triggered by stress and things like that. So HRT doesn't always
hair loss. Yeah. Hair loss was another one that was the very first symptom I had.
Thinning hair.
And it is very depressing as well. But it's not. I just try to do other things, take supplements for that, use good shampoo and conditioner, all that sort of stuff. But I never, I didn't actually go about HRT, and try wash it as less as you can, all that good hair health stuff. It wasn't the reason I went to speak about HRT, though. That was but it was one of the first things that happened to me. So another question I got asked was, is there anything that, so the younger ladies that follow me are thinking, in their 30s, that don't have any symptoms, that are totally fine, thinking, should I be doing something earlier in life to help me prepare and set me up for...
No, absolutely, that's a great question.
I thought that as well.
No, because I mean, it's coming.
Yeah, exactly.
So, don't wait for it to happen before you then go, oh gosh, I better get those good habits going now. It does help, in your 30s to start thinking about, what should I be doing, to help prepare me for those later stages in life. And, it is, again, lots of lifestyle things, stop smoking. If you're a smoker, stop smoking. Look at your exercise. Are you getting enough exercise? Start building that into your sort of like daily routine, so it's easier to then keep going with it. Because it's really difficult to start exercising when you're in your 50s. It's easier to continue exercising when you've been exercising regularly.
And when you say exercising, is it as simple as taking a walk?
Sometimes, I mean, if again, it's one of these things I just say, find something that you enjoy doing and just do it. It's better than not doing anything at all. You do have to think about all the different types of exercise. So it's not just like, aerobic. That's good, but you also need to think about, you do lose muscle mass when you go through menopause. So you do need to work on maintaining or building up your muscle mass. So you don't have to, look like Schwarzenegger or anything. It's just, but a little bit of work on your muscles, do a bit of stretching and work on your joint flexibility. Because again, joint aches and stiffness is another thing that a lot of women experience when they're going through the menopause. So, you're trying to sort of like do all the exercises that will be specifically beneficial for all those things, like muscle loss, joint stiffness, as well as a bit of aerobic exercise. So it's getting into those good habits, taking a really good look at your diet. What are the things you can cut out? What are the things you can do? If you're not someone who enjoys cooking, and you rely a lot on, those highly processed foods, it's time to start trying to cut those out.
Cut out the pot noodles, for one. Start the lifestyle changes as early as possible.
As early as you can to get the most benefit.
And another lady asked her mum, I thought this was a good question as well. Her mum is going through menopause and she's just a young girl herself, and she's asking what can she do. And there'll be men out there that'll feel like that as well. I know, and I did think that was so considerate. What could she do to help or support her mum? Which isn't really the type of advice you give.
But I guess it does matter, because women are not going through this in isolation. They have children or husbands or partners. They've got job, they've got work colleagues that they're having to deal with. So I guess if you are one of these people and you see someone struggling, then it's have a bit of patience and understanding.
And even what I thought was, I've done my own podcast on talking about perimenopause. Listen to these podcasts. Listen to this podcast. I'm sure she will anyway, because she follows me. But
just realise that somebody's going through something, and and sometimes just a little bit of take on a bit of their load. Because I think we forget that women, whether we like it or not, we tend to take on the biggest burdens in the household when it comes to the
We're the
childcare
project
and
manager
housework
for everything.
exactly.
In the house.
So you know, it's like sometimes just try and make things a bit more equitable in the household, to just take a bit of that load off, take a bit of that stress off. Give her that time that she needs so that she can actually go and do the exercise.
Yeah, and I think that is a huge thing as well. I mean, if women are just trying to understand it themselves and how massive it is and the huge impact it has on their life, then we also need a wee bit of understanding from the people that are in our lives of how huge it is.
Yeah, and communication as well.
Yeah.
'Cause sometimes you do see women, they're coming in on their own and they're just saying, feeling terrible, and my partner thinks I'm going mad, and the relationship's suffering. And then you see the woman who's coming in with her really supportive partner who's saying, oh yeah, I know she's going through all of this and I want to do what I can to help. And you're just like, oh yeah, that's the way to do it.
It's communicating that you need that. Yeah, because like my husband, for example, knows nothing about it other than what I tell him, and then I'll say, I've got this HRT, and he'll say, oh good, does that mean you'll stop being so crazy, as a joke? But, at the same time, I'm very lucky that he does let me do whatever I like. If I need to go and do something. Anyway, moving on, this is valuable time. I'm slagging my husband. But at 57 minutes now. Right. Somebody had asked, what can you expect at a menopause clinic?
I guess, it's the sort of consultation where it's, getting to know that person, what they're going through, what their medical history is, because that is always relevant, and then, discussion about options, risks, benefits, other things that can be done alongside all of that.
Yeah, so kind of this conversation is pretty much what you would do in a menopause consultation. So everybody's getting one free menopause consultation.
Yeah, I know, it's really difficult. Because you could. I mean, what we've spoken about has all been quite general stuff.
Yeah, but that's how you would start. Surely that's where you would start, asking all those general questions to then get more specific.
Yeah, and it's and it's trying to just figure out what would suit that woman, what her expectations are, what her fears are. Because like you said, somebody who's one of the gene carriers. Yeah. Again, that's quite a detailed discussion about what's your personal history versus what's the family history. All of these kinds of things. So.
So to finish off then, because we are coming up to the hour, in terms of booking a consultation with yourself, if somebody wanted to go down that road, I know it's not an option for everybody.
No.
Affordability comes into
it. Not everyone needs to.
No, exactly. And you would, I'm assuming that you would urge anyone feeling at a loose end who's done all their research, knows their own symptoms, has got that diary and whatever, to press for an appointment at the local GP.
So see your GP first, or your practice nurse who might, be running a menopause service. Do that first, and it's not always easy to get an appointment, but you will be able to at some point.
Yeah. Well, at my practice, it's the nurse, like I say, and I think if you're asking,
great to have that service.
Asking the receptionist. I know we've all, got issues with that as well, but just asking the receptionist, is there anyone at the practice who specialises in menopause care or perimenopause care or whatever? And if somebody did want to book a consultation with you, online, Cosmedicare, you're there, you're on Jill's website, because I googled it this morning.
Okay.
I mean, I don't know if you can't book appointments, but on the website I'm sure you need to phone, but if you Google your name under Cosmedicare, you come up there, so people can book an appointment or chat even about how to book an appointment by phoning Cosmedicare. Fabulous. Thank you so much, Dr Malini. I'm very privileged to be able to have this conversation with you. I know, and I hope that helps just, get some of the concerns and anxieties waylaid a wee bit by the people that are watching, and if we can do another one,
Yeah,
we
sure.
will. Thank you. See you later. Bye.